youth in Uganda, including the key populations, basically tackling HIV prevalence. I'm here to thank you all for joining this wonderful webinar. I see a number of participants. Yeah, and I'm really grateful that we are all here. Yeah, so I'll do a quick introduction and welcoming. This webinar is basically about the inclusive justice, age of consent, and abortion, together with HIV treatments. Yeah, so as we wait for like other panelists to come on board, I guess now we know why we are here, and I'll give us more introduction. As I welcome the other speaker to do the biggest introduction. Yeah, so as we all know that there's a lot of injustices that encompasses the equitable treatments of all individuals, particularly marginalized groups in legal and health systems in all our countries and our regions. We all know that. But before we go forth, I would love everyone to like introduce themselves in the chats. Please, let's introduce ourselves in the chat box as we wait for the rest to come on board. Yeah, so today we shall look at those injustices that we have, especially when it comes to like HIV treatment for young people, and then the other people living with HIV in all settings of our communities, and also to look at the abortion, the age of consent in HIV testing and treatment, and also age of consent when it comes to like abortion. Yeah, so I hope we are all now introducing ourselves in the chat box. I am seeing Catherine from Zimbabwe. You're welcome. Yes, everyone, please put your names and where you come from and on the organization in the chat box so that we know whom we are with. Yes, I see people from Nigeria. Thank you for joining. I see from Zimbabwe. Thank you for joining. Yes, keep them coming. Keep them coming. Keep them coming. I see people from Kenya. Thank you for coming. Thank you to, I see from Eswatini. I see from Zambia. Yes, I see now we are having a marginalized group, and we are trying to make sure that everyone is included in such talks. Yeah, as we know, abortion remains a continuous issue with legal restrictions when it comes to people affected with HIV and young women and those from low-income backgrounds. Yeah, so the World Health Organization estimates that unsafe abortion accounts for 4.7 to 13.2% of maternal deaths globally, with adolescents facing high risk due to lack of access to safe abortion services. And then in many countries, they are so restrictive when it comes to abortion laws, and do not consider the complexities of consent, particularly from minors, or from marginalized groups and health disparities. So I guess now we know where we are here, and we are here to talk more. And I'd love to welcome our speakers to come and do their introductions. I see Dr. Tanaka. Would you want to do more on this introduction as before we go to the speakers? Dr. Tanaka?
Okay, thank you so much, Sharon. And welcome everyone to this webinar. So I would like to give a little bit of an introduction to this webinar, and also to talk about our speakers for today. So allow me to first start with the the title of the webinar, which is Inclusive Justice, Age of Consent, Abortion and HIV Treatment. So inclusive justice encompasses the equitable treatment of all individuals, particularly marginalized groups in legal and healthy systems. Central to this discourse are issues surrounding the age of consent, abortion rights, and access to HIV testing and treatment. And then, according to the World Health Organization, it estimates that unsafe abortions account for 4.7 to 13.2% of maternal deaths globally. And also, I will jump on to the intersection of age of consent laws and HIV treatment, which is very critical, and the joint United Nations program on HIV and AIDS, which is the UNAIDS report, that young people aged 15 to 24 account for 34% of all new HIV infections globally. Therefore, I am going to go to our first speaker. Oh, I didn't realize that my phone got muted somehow. So sorry, very sorry. Can everyone hear me?
Yes, we can hear you.
That's great. Thank you for the confirmation. Okay. Now we are going to our speakers. I'm just going to do a rundown of telling you who our speakers are. We have Dr. V. Chandra from World Health Organization, and also we have Elizabeth Atieno, who is Africa Young Sex Workers Alliance from Kenya, from Africa Young Sex Workers Alliance from Kenya, and also we have Welisane Magbo, who is from Cameroon, and Ketra Ruth, who is from Uganda, and Margaret Nyambura from Kenya. So thank you. I leave this time to the next speaker. Thank you. Hello, Sharon, are you there?
I think Sharon, she has left the call.
Oh, she has.
Yes, she's back.
Oh, sorry guys, I got a connection problem. I've not been on, but we can proceed. Or I can be guided because I don't.
Okay, I had just finished giving a brief background about the webinar, and also introducing the speakers, but not in detail. I just had to tell the name of the speaker and then the organization and the country they are coming from. Thank you.
Okay, thank you so much. I think the speakers can, maybe they can introduce themselves. Maybe we can start with Ketra from Uganda. Ketra, can you please unmute and you introduce yourself?
Hi, Sharon. Thank you for this opportunity. I'm Ketra from Uganda, Ketra Nansambarus. I'm so happy to be part of the webinar. And I work under MJAP, Makerere Joint AIDS Program. I also work with PATA. I also work with not IDI. I also work with ROM. I'm a YAC. I sit on the advisory board committee. Basically, I'm a community person. I do community work. In brief, that's what I think I have. Thank you.
Okay, thank you so much, Ketra. So to the people, thank you.
Good afternoon, everybody. Can you hear me?
Yes, you are audible. You can proceed.
Great. Good afternoon once again. My name is Margaret Nyambura. I work for the Kenya Legal and Ethical Issues Network on HIV and AIDS, KELIN. I am an advocate of the High Court of Kenya for about 4 years now, a health justice advocate. I have worked in some areas around sexual and reproductive health and rights, HIV, COVID, universal health coverage now that my country is rolling out new social health insurance plans. And I'm happy to be here today to contribute to how ages of consent act as a barrier to accessing HIV care as well as abortion.
All right, thank you so much, Margaret. And maybe our other speaker, Aweli Sen, is it Magbul? Could you please introduce yourself from Cameroon?
Accept warm greetings, everyone. Of course, I come from Cameroon. I'm a young champion advocating for the empowerment of young people, especially adolescent girls and young women in all our diversity, with a focus on sexual and reproductive health rights. I do design communication strategies and advocacy campaigns that address the needs of diverse youth, including those with different sexual orientation and gender identities. I do support grassroots organizations in Cameroon, both the English and French-speaking regions, mentoring over 100 young people in community-led advocacy. I do amplify marginalized voices, promoting equitable digital health environment. I currently do serve as country focal point with ATHENA Network What Girls Want program, and I am also programs manager for Pan-African Network of Gender Justice. Thank you.
All right, thank you so much. Then we shall go to our other speaker, ATHENA. Please unmute yourself and introduce yourself. ATHENA, are you on? I think ATHENA is not ready. Maybe we can go to Dr. Chandra. Dr. Chandra, would you please unmute yourself and introduce yourself to the people? Okay, without wasting any time before other speakers come to introduce themselves, maybe they are not ready. We shall go straight and start. Yeah, and I would love us to really know, according to our different countries, and how does justice and age of consent, putting it together with abortion in a HIV treatment is done. And we shall start with Ketra. Ketra, in your experience, how do laws surrounding age of consent, sorry, just a moment. Okay, sorry about that. So Ketra, in your experience, how do laws surrounding age of consent and reproductive rights impact the effectiveness of HIV treatment and care, particularly for young people living with HIV who may also face barriers to accessing other health services? Ketra? Ketra, are you ready? Can you hear me? Can everyone hear me?
Yes. Yes, I can.
Yes.
Okay. Ketra, are you ready? I think she's having some trouble. Maybe we can go ahead and then to the available speaker. Wilson, are you ready? Wilson, are you ready?
Yes, I am ready and I hear you, Fiverr.
Okay, what are the most significant challenges young people and young key population face when accessing HIV treatment, sexual and reproductive health services, and abortion care, particularly given the legal restrictions and culture stigma in many regions? Over to you.
Amazing. So I think the first speaker would have been able to touch around consent, but because the first speaker have not been able to speak, let me just be able to draw some context around that. Consent is a fundamental concept in both international law and national legal frameworks, including the Cameroonian law, of course, from where I come from. Consent is the agreement or permission granted by an individual for something to happen or be done, particularly in the context of healthcare, sexual relations, and legal rights. And informed consent is even a crucial principle ensuring that individuals have the right to make decisions about their health and medical treatment. Now, going to the question, young key populations in Cameroon, just like every other part in Africa, do face several significant challenges when accessing sexual reproductive health services, especially within the context of HIV treatment and abortion care. These challenges are exacerbated by legal restrictions and cultural stigma. Let me touch on criminalization within the context of legal restrictions. You know, laws against same-sex relationships do deter LGBTQ communities, adolescent girls and young women in all our diversity from seeking HIV treatment and abortion care due to fear of legal repercussion. For instance, let me talk about the Cameroon Penal Code, which punishes same-sex relationship in its Article 347 with a penalty of 6 months to 5 years imprisonment and or monetary fine. Under Article 337 to 339 of that same law, abortion also is heavily criminalized, punishable from 1 to 5 years imprisonment and or monetary fine, restricted and only permitted in cases of incest. This will be blood relation sex, in cases of rape as well, and also when the pregnancy is injurious to the mother's health. Now, abortion's care consent is highly determined by the law. By implication, we are saying that even the consent of the person who is pregnant has no effect. So the legal environment discourages young key populations due to the risks of arrest and harassment. Let me move further to touch on cultural stigma. Social norms denounce us seeking sexual reproductive services, particularly those of us who are sexually active outside of marriage or belong to marginalized groups. Why are you getting pregnant when you're not married? Why are you seeking access to contraception when you are not married? You know, especially in an African context, we tend to avoid healthcare facilities for fear of being judged or discriminated against by healthcare providers or community members. I remember, supported by Y Plus Global earlier this year, I was able to implement the My Reality campaign in Cameroon, where we're able to share lived experiences as young people, calling for stakeholders' accountability while amplifying our voices. Also, as country focal point for ATHENA, we're able to implement the No to Judging Us campaign, where we're calling for unrestricted access to all SRHRO services. I'll touch on financial barriers and then I close up with information gaps. You know, under financial barriers, high costs associated with healthcare services can be prohibitive, especially for young people who may lack financial independence. You know, across Africa, how many young people are even employed? How many of us do have income generating activities? How many of us truly have money to say that we really want to take care of our health? You know, traveling to health facilities can be expensive and logistically challenging, particularly in rural areas. I always tell people, you know, depending on our different currencies, where I come from in Cameroon, the shortest distance is 100. It's not even up to $1. But there are young people who do not have that to be able to even go to healthcare facilities for consultation. Wrapping up with information gap, as young people, we are often subject to misinformation regarding HIV, contraception, and abortion, which can even lead to unsafe practices and poor health outcomes. Let me touch on HIV treatment on its own. We have stigma and myth around that, you know, HIV transmission, HIV treatment, you know, it discourages us from testing and care. What are we being taught in school, how HIV is being transmitted? Sometimes we are told at the elementary level that if you even shake hands, if you even wave, you know, HIV can be transmitted by greetings. It's not true. It discourages us from testing because, oh, what if I've shaken hands or waved someone living with HIV? It means automatically it has been transmitted. So I'm not going for any test because I know what the result will say, you know, leading to undiagnosed infections, the fear of disclosure. Concerns about revealing HIV status do prevent us from seeking necessary medical help. Once I am being tested, it means the healthcare service provider is going to spread my news, and I'm not doing that. Once I come back and I'm sat in my community, people are going to dictate that something is wrong and the news will spread, so I'm not testing. You know, many of us are unaware that there are even effective treatment. Get to the health facility first and let's be able to move from there. There's adherence misunderstanding as well. There's a whole lot of ignorance about the importance of consistent medication, which can lead to treatment failures. From our African context, I know of instances where we go to our churches and they tell us to stop treatment, that the Lord has healed us. It doesn't happen like that. There's a place of science. There's a place for treatment. Under abortion care, as I wrap up, we have legal misinformation. You know, we do lack awareness of our own rights. I talked about when I shared the context of Cameroon, what the law says. If we as young people are able to pick up these laws and we're able to read and understand them, then we can be able to identify certain gaps. When I read the Cameroon law regarding abortion, I understand that it is not illegal but restrictive, which means that as a young person, I can be able to influence policymakers and stakeholders and say that, hey, there's a gap here. It cannot just be influenced by the law, but I, who is carrying this pregnancy, unsafe method. You know, we prefer to go around the corner and get concoctions. I was working with a grassroots organization the last time. We're doing a research on abortion. The things I heard in the communities were scary. You know, it's important for us to know the safe methods that are available. The emotional impact itself, stigma surrounding abortion leads to feeling of guilt and shame. That's what our communities have created, deterring us from seeking support. And lastly, the health risks that are involved. Many of us do not even understand the severe complications that are associated with unsafe abortions. You know, sometimes when these documents, these fact sheets are uploaded, this research are uploaded, it's important for us to take them and read. When we read and understand the consequences, then we can even know that we need to amplify our efforts. Thank you so much.
Okay, thank you so much for the well-detailed presentation. So now we are calling on Ketra. Ketra, are you now available?
Yes, I am.
Great. We had lost you. So the question is, in your experience, how do laws surrounding age of consent and reproductive health rights impact the effectiveness of HIV treatment and care, particularly for young people living with HIV who may also face barriers to accessing other health services?
Pardon me?
Okay. Your question is, in your experience, how do laws surrounding age of consent and reproductive rights impact the effectiveness of HIV treatment and care, particularly for young people living with HIV who may also face barriers to accessing other health services?
Okay, thank you so much, Doctor. In my own experience, the age of consent is basically from if you're 12 and above, if you're 12 and above, you can consent by yourself. If you're 12 and below, it is always a parent to help you consent for anything that is going to occur around the hospital or something. So I basically
Ketra, we lost you. Can you please unmute yourself? I think you muted yourself. Ketra? I think she's having issues with connecting. Maybe we can pass this question to another speaker. KELIN, are you ready? Can you please go on and maybe maneuver through and talk about how the age of consent and the laws surrounding it and the reproductive health can really impact? Yeah, can you please go on and maneuver through, because I know you're from Kenya, and most of the laws in Kenya and Uganda are almost the same. Over to you, KELIN.
Good afternoon, everybody, once again. So the question was, in my experience, how do laws surrounding age of consent and reproductive rights impact the effectiveness of HIV treatment and care, particularly for young people living with HIV who may also face barriers to accessing other health services? I'd like to take over from what the very first speaker said, because in so many ways our circumstances are similar. So you find that the problems surrounding the question of access, not just access because of legal barriers around consent, and as Ketra had started us off, age of consent in Kenya also is capped at 18 years, and this is according to the Constitution. That's Article 260, which covers a wide continuum of definitions in different circumstances. But I'd like us to draw a demarcation between what it means for age of consent for sex and age of consent for access to care, age of access to care. So for Kenya, the age of access to care is at 15 years. That is age of access for HIV testing, age of access for HIV treatment, as well as age of access for pre-exposure prophylaxis. So what you find is that the case in Uganda is slightly different. Just like Ketra was saying, the Ugandan case is 12 years for age of access for HIV treatment, 12 years for age of access to testing, and then no restrictions for age of access to pre-exposure prophylaxis. That's for HIV care. But the instances for abortion and related reproductive rights, we find that we are still having an issue on the question of giving adolescents age-appropriate sexual and reproductive health and rights services because of the question of parental consent. This is covered in the Children's Act of 2022. It is also constantly debated every time the adolescents, youth, and reproductive health policy is up for renewal as it is right now. The whole policy document will circulate, and the only three questions will come up. Are you asking to give children contraception? Are you placing a requirement for parental consent for you to do that? And where is the access? Like, where is the facility where they can get this? The whole policy document revolves around those three questions. So similarly to the very first speaker from Cameroon, we have got Article 26 of the Constitution of Kenya covering the circumstances under which abortion may be permitted. Also in Kenya, it is not illegal but restricted. That's the language that we use. So that they have pegged it on the opinion of a trained health professional, that should this trained health professional find that there is a need for emergency, one, or the life of the mother is at risk or in danger, if the health of the mother is at risk or in danger, or if permitted by any other written law. So on those four circumstances, then there is a permissible or unrestricted access to reproductive health services, or rather, if I may, abortion. So I'd like to particularly respond to the issue of emergency treatment and any other written law. We have got the post-rape care guidelines in Kenya, and at this point, it doesn't matter what age you are. One of the details in the package of care that you are entitled to once you seek medical attention in a health facility is post-exposure prophylaxis and emergency contraception. And in some instances, as we have seen from practice, termination of pregnancy, if at all the survivor of sexual violence has accessed a health facility beyond the 72-hour window, which is allowed. Now, we still have a lot of barriers to this because, one, health facilities are far and wide apart. There's the issue of finance as well. Then remember that to make it legal, you have placed it on the if I may call it, the opinion of a person. So you place it on the training of healthcare providers. So we are imagining that I today am a survivor and I'm accessing health facility, let's say the Mama Lucy Kibaki facility in Nairobi, and I come across a trained healthcare provider who is not familiar with the concept of delivering adolescent-friendly services. Now, let's just start from that point and say that it may be very difficult for you to be in the hands of a very judgmental healthcare provider who would like to apply their own attitudes and values at the point of access to care. That is also going to be a significant barrier. So when you look at laws which further exacerbate this, you find that these are really difficult barriers because nobody wants to be on the wrong side of the law. Then we have the penal code, and we have got very problematic sections around the person who is discharging or rather dispensing the drugs that you're going to utilize for abortion, the person who is aiding you in taking them on, and you, the person who is seeking the service itself, right? All those are still penalized. There has been ongoing advocacy around this with the PAC case, and now it is at appeal, and KELIN is participating in this litigation to see to it that there is a congruency between what the Constitution says, very progressive in alignment with the Maputo Protocol. Then there is what the Penal Code says, and then there is what our own Health Act 2017 of Kenya says. Now, we have covered some ground as far as training of health professionals goes. We've tried as much as possible, but of course not without the interference of opposition actors. We have also tried as much as possible to train some judicial officers. These are both magistrates and judges, and they are alive to the particular needs of young people. Now, specifically, if I may speak about gender and sexual minorities, here we have got the additional barrier of if you pass a law, for instance, in Uganda, like the Anti-Homosexuality Act, and I'm to access care at a facility, and I'm afraid, first of all, I'm apprehensive that you're going to tell that I'm of a different sexual orientation, or at the point where you require me to bring forth who my sexual partner is for purposes of contact tracing and also just for administering of similar medication, then I'm going to be apprehensive, and therefore there's not going to be duplication of health, or rather the medical service is not going to be given to both persons, right? And therefore that's another barrier that we look at, because it's also a law that is surrounding access, because I'm afraid that you're going to out me because of my different or diverse gender or sexual characteristics, and therefore I am unwilling to come forward to get access to care. There is also just the barrier that is stigma. It may not be put in law, but in Kenya we have seen it under Section 26 of the Sexual Offences Act, which makes it a criminal act for you to knowingly infect another person with HIV. Now, this is very problematic. We are also in court challenging this. And every time I tell people it would be a prosecutorial nightmare, having practiced criminal law, I can tell you that given the criminal, the requirement there is that the evidence should make it that beyond any reasonable doubt that X is the one who infected Y. How exactly are you going to be able to prove that for a court that is sitting over this matter to pass a verdict? It would not only be discriminatory, it would also be almost impossible to prove. That's also another barrier that we face. And I always say that it is important to look at the context we are speaking in. It is the year 2024. Adolescents are anywhere between the age of 10 to 19, as far as the advice from the World Health Organization goes. And also we have borrowed similar practices for placing adolescents in that age bracket. I'd like us to dial back about 20 years from now. The year is 2004. If anything, at around this time is when any plans under the Presidential Plan for Emergency the PEPFAR, Presidential Emergency Plan for AIDS Relief, the programs were being rolled out and people were still reeling in the effects of stigma. Couples were not aware of their HIV status and they were still getting children, and some of them had not yet gotten access to prevention of mother to child. So you find that even as we keep on having testing done for the demographic of between 10 to 19 years of age, you find that these infections may have been passed down during childbirth, and the adolescent who is seeking services at the hospital is barred by this legal restriction. So for instance, when you look across Africa, you find that the country that has got the lowest mark is Mozambique at 11 years for access to testing, 11 years for access to treatment, and 15 years for access to pre-exposure prophylaxis. And then followed closely by countries like Burundi, Eswatini, Lesotho, Rwanda, South Africa, and Uganda with 12 years for both access to testing and access to treatment. Now, what does this look like against the recommendation by the UNFPA that we set 12 years as the minimum age for access to medical treatment, and we set 10 years for age of accessing sexual and reproductive health and rights related testing and services and commodities as well, if at all we are going to speak about prevention. Now, on the other hand, when you look at the ages of 12, of 11 from Mozambique, 12 and 15 as we've gone down, I would also like us to mention that there are some countries such as Seychelles and Tanzania, as well as Zimbabwe, which do not necessarily have an age for restricting access to PrEP, but they have got this blanket cover of parental consent required and the age is not specified. Now, friends, I would like us to consider the instances where there are no parents in the question, there are no guardians, and the best interest of the child, because if you're below the age of 18, the best interest of the child at this case require that you access a service because your health is at risk or your life is at risk, if at all it is in the instance of seeking an abortion-related service. Then if you place the requirement for a parental or a guardian's consent, this is a significant barrier, and the young people are not likely to get the service. Now, these things may be one thing looking at them as statistics from a paper, but at KELIN, we are often in a scenario where we have got to give representation or advice or to connect a service provider to a person living with HIV, and they tell us that If it were not for poverty, my second child would not have gotten HIV at birth. I wasn't able to go to a facility, I got the child at home. So you see, these barriers are in actual real lived experiences of people. And I'm happy to later on in the webinar speak about some of the recommendations we may have towards doing away with these barriers. Thank you.
Wow, thank you so much. That was a very good detailed presentation, and I like the way you have put together the context of different countries. Actually, that was very important. So allow me to let you know that our keynote speaker is on now, Dr. Chandra. You are welcome. In a few moments, we shall give Dr. Chandra a chance to introduce themselves and also present, because we have a few minutes to go. And please, I would request everyone to use the Q&A. Whatever you can go in and put your question. You can ask it directly to like any speaker you would love to. After Dr. Chandra's presentation, we shall have to go into the Q&As. Dr. Chandra, over to you.
Thank you very much. And my apologies for joining late with the change to the winter time in Europe. I mistook the time of the start of the webinar. I've been listening to the last presentation, and it was very interesting. My presentation is much more about the knowledge of brain development, psychosocial maturity, and WHO's recommendations, taking that into account. I don't know whether that is useful to you at this stage in the webinar. There were lots of pertinent, concrete issues raised by the previous speaker. And if it makes more sense for you to continue the discussion, then I'm happy to step back and just listen to the discussion. So please advise me, Chair.
Please go ahead. Actually, it is very, very important for you to give us the context of your side for us to really be guided even before we go into other speakers. Yeah, over to you, please.
So I understand that you are going to end your webinar at 3:30. So I will try to finish my presentation in 15 minutes. And I'm very happy to follow up and respond to comments and questions by email. Can you see my slide, please?
Yes, please.
Okay. So what I'm going to talk about is our current understanding of brain maturation and of cognitive, social, and emotional development in adolescence, and the implications of this for our work. Many of these points relate to the points made by the previous speaker about the complete lack of coherence between consent for sexual activity, consent for contraception, consent for sexually transmitted infections care, and so on. And so where do we go with this? So brain maturation. Adolescence can now be understood as a dynamic period of brain development. And according to the Lancet Commission on Adolescent Health and Well-being, it is only second to infancy in the extent and significance of the changes that occur in the brain system. 3 points on brain maturation. Previously, it was believed that brain development ended in early childhood. We now know that it continues through childhood, through adolescence, the second decade of life, and into early adulthood. We also know that during adolescence, profound changes take place in brain connections and signaling mechanisms. And some of the most important changes are in the prefrontal cortex, which is responsible for organizational ability, strategic thinking, and impulse control. We also know that brain changes are affected by social influences. Heavy use of alcohol, heavy use of illicit substances, experience of adverse childhood experiences such as violence, can have huge changes in the structure and the function of the brain. So this is the a diagrammatic representation of the brain. And what you see here is that the reward center, which is shown in purple in the heart of the brain, is different from the judgment center. The reward center develops earlier than the judgment center and that's therefore responsible for many of the actions that the adolescents take. When an adolescent is driving at a very high speed, it is not that they don't know the dangers of road traffic injuries, but it is that they are perhaps surrounded by friends and egged on by rewards, which are much stronger than the wise counsel that the judgment center of the brain provides. So the last point in relation to this section of my presentation, when making decisions, adolescents seek out and are more influenced by exciting, arousing, and stressful situations compared to adults. Adolescents are more affected than adults by hot cognition, by exciting or stressful situations. So as I said, in the Lancet Commission, it was noted that, previously we used to think that, adolescents can make poor decisions because they were intellectually not aware of issues. On the other hand, there's nothing by the age of 15, many adolescents have the intellectual abilities to think through issues just like an adult does. It is the judgment centers of the brain which are in question. And this is, of course, misused by many authorities to withhold the abilities, the legal ability of adolescents to make decisions. And I'm going to come to I'm sharing this information because it can be useful in making arguments with decision makers and influencing change. So this is a wonderful National Geographic article. If you're interested, I can send it to you all. And, this is the author talks about getting a phone call from the jail where his son was arrested driving at very high speed. And he told his son, "Aren't you stupid? Don't you know you could kill yourself?" And the son told him, "Dad, I knew exactly what I was doing, but it was fun doing it." So they're not stupid at all in that situation. Cognitive development. During adolescence, 3 points here. Thinking shifts from concrete to abstract, reasoning skills become stronger, creative abilities blossom. So, the whole ability to think changes. And it occurs at a variable speed. It's affected by social and cultural context, by alcohol and drugs, as I mentioned. What are the implications of this? The implications are, as an adolescent's thinking moves from concrete to abstract, from early through middle to late adolescence, we need to support cognitive development by seeking to assess their thinking abilities, by stimulating their cognitive thinking, and helping them make decisions using these newly developed abilities. So getting them to practice decision making, showing the benefits of future thinking, demonstrating to them how one makes decisions. Just like, you have to strengthen your biceps and your triceps through, dumbbell exercises and weights, you have to strengthen the ability to make decisions. And that also needs to be practiced. So you can't suddenly one day say to an adolescent, "Now you're an adult, you can make decisions on your own." It doesn't work like that. Social and emotional development, 3 points again. The nature of social relationships changes from early through middle to late adolescence, as shown on this slide. And in adolescence see parents and other adults with new eyes. jokingly one could say, one day the father was the hero of the son, and then 2 years later, the son says, "Is this the man I thought as my hero? What an idiot he is." And then, 10 years later, when they grow up and they are in a different stage in their life, they say, "Dad, I understand where you're coming from and who you are, and I have so much more respect for you than I had when you were an adolescent." I can promise you, I went through the same journey with my son. So this is a very important issue because this is very much to do with how young people relate to adults, including adults with authority, such as police and health workers and teachers. As they navigate through adolescence, individuals face challenges and experience stress. Stress can be good. It can push people to do things, but when stress is prolonged and intense, it becomes toxic. And there is growing evidence of the toxicity of adverse childhood experiences. So what do we do about it? To deal with others sensitively and effectively, adolescents need emotional and social competencies. Emotional competencies is the ability to perceive, assess, and manage one's emotions. Social competencies is the capacity to be sensitive and effective in relating to others. We talk about 4 things. Self-awareness, that's being aware of oneself. Self-management, that being able to manage oneself. Social awareness and social management. And this is all so important in life, something that we are never taught of. You can go and get a driving license, you can learn how to bake a cake, somebody can teach you how to ride a bicycle, but these important emotional and social competencies, which are so crucial in our lives, in our marriages, in our work environments, in our relationships with siblings, no one teaches us. So coming to the end of my presentation, bringing the threads together, what do we do? I'll skip this slide. What are the implications? We must support adolescents in making well-considered decisions. We must help them understand how the physical presence of peers, as well as their influence, affects them. And that may be, about unprotected sexual activities, substance use, getting on a motorcycle and riding it after 2 or 3 rounds of beer. We must help them understand the roles of emotions in decision-making. At the same time, we must make environments safe for adolescents. For example, in London, they decided at one stage that Friday evening people get angry, they fight, they beat each other up sometimes. And so, what they did is they stopped selling glasses for beer. What they started doing was they give plastic glasses so that people can fight with each other, but they can't kill themselves. So I close with 4 implications. As an adolescent's thinking shifts from concrete to abstract, health workers should match their communication to their assessment of the ability of the adolescent patient to think abstractly. So there was a mention about sexuality education. This is a book I used in teaching my son, questions children ask, answers to give. The second point is adolescents' reasoning becomes stronger. Health workers should encourage a deeper understanding of issues, pose open-ended questions, and avoid mocking or criticizing adolescents' thoughts. Do you want to be an artist? It's a stupid choice. You'll never earn an income with that. Being aware of potential risks does not stop someone from carrying out those risks. Health workers need to understand the role of, help adolescents understand the role of emotions in decision making, and just say no and don't do that just don't work. What WHO has done is now provided governments and ministries of health with guidance on how to support adolescents to make decisions in the presence of such issues. When adolescents may want to make a decision such as an HIV test or termination of pregnancy, how do they decide that the adolescent is a mature minor based on their assessment of cognitive development and their emotional and social competence? This is a guide that is used, and I can make this available to you if you don't have it. This is something that many countries can use because, there is flexibility that governments have and government ministries of health have in using such tools to allow decision making based on joint exploration, the common synthesis of the situation, and a decision point as recommended by WHO. And finally, in a situation, what do I need to do? This girl of 14 is having sex. I cannot give her condoms because it is illegal, but she's having sex below the age of minority. Should I report her? And constantly the challenges are, is it ethical? Is it legal? And within these barriers of ethics and law, what is it that I can do which is practical? And to conclude, ultimately, everything has to do with decision making. Support adolescents to make decisions in situations where no adult is available to help them, guide them, and they have to make the decisions that they can as best as they can. And so what we need is to support adolescents to make the decisions and help health workers in many areas where there are laws which are restrictive, but allow health workers the space to give adolescents the ability to make decisions and move forward. Let me stop here. I'm going to stop sharing. I don't know if this was useful to you. I'm sorry if it wasn't, but I'm very happy to contribute to any discussion on this going forward. Thank you, Chair.
Thank you so much, Dr. Chandra. That was very, very insightful because I believe all of us here are working with youth and adolescents, and it is so much important for us to prioritize the adolescents' health, especially the mental health, and more for them to like always access services and treatments. Thank you so much. That was very, very insightful, and we are very, very happy to have you. Your presentation has been corresponding correctly with the previous speakers because today's session is more about young people, and when we talk about inclusivity, we really mean including each and every young person in a different perspective of health. Yeah, so thank you so much, Doctor. And we shall still go ahead with our next speaker directly. We shall go to Elizabeth. Elizabeth, with your experience, how can we create a more inclusive legal environment when young people are empowered to participate, particularly for those living with HIV, to seek abortion and HIV treatments without fear or stigma or discrimination, and as well putting across criminalization of HIV. Elizabeth. Elizabeth, are you with us? Okay, I think she is not able to speak right now. I think everyone is still wondering to know, everyone is eager to know about the laws and the age of consent and reproductive health and rights. I don't know if our other speaker, Ketra, can you please come on and you take on your question? Ketra, are you able to speak now?
Yes, Sharon, thank you. I'm back. Guys, I'm sorry, my network is really poor. It goes on and off. About that, as I said earlier, the age of consent, if you're 12 and above, you can easily consent for yourself. If you're below 12, you need a consent from your parents. And it is here in Uganda, if you're not 18 and above, we don't see you as an adult. So in most cases, these young adolescents come and they want to access some of the services, but just because they are below the age, they cannot access them. Their parents have to be there, and their parents bring in politics. What I mean by politics is that they come up with excuses of so many ideas of what they think is wrong. Like when it comes to if a kid, I'm talking of the art part, if a kid is having issues with their medication, automatically they have to talk about that. But in most cases, we want to talk with the kid first with the parent before we engage the kid alone. So in that, a parent has to consent before. So most of the times, parents tend to give out excuses, I'm not ready, smile, the kid is still young, what, on all that. Whereby this kid is already having a clue on whatever they are facing and having some bit of information, but they just want clarity on why they are doing their medication. So with that, it leads to stigma amongst themselves, and it also comes up with the bad taking of drugs, which brings in bad adherence amongst those adolescents. And this also comes in with the abortion part, whereby most of the kids come to this kid who was raped and they're underage. This kid wants to abort. How will this kid abort if the parent does not allow abortion, thinking that abortion is killing? But remember, I'm raped and I'm facing challenges in the community. People are pinpointing me, looking at me as a bastard, all that. And you cannot let me abort just because you think abortion is not safe. Still in the community, these parents and caretakers tend to torture these adolescents, like in terms of consent when it comes to financial issue. A kid might be wanting something that they see that it's beneficial or it's going to help them somehow, somewhere. And just because you cannot consent for that thing you want, the parent will nearly not let you go for it just because they feel it's not right for you. You're still a kid, you're still under their caretaking, so you need to first reach the age they feel like you have to. You have this age, it is when you're going to access that thing, the service you want or anything you feel like you want to get. Yeah, that is what I have.
Okay, thank you so much for bringing up the community parts. Like for you, a person who has been working in the community, you really have a lot of perspectives when it comes to in-person treatments. I think that was so insightful. As we go into our Q&As, I'm seeing a question. I think this question goes to Dr. Someone is asking, how can a non-profit organization effectively collaborate with the World Health Organization to enhance support for programs targeting adolescents and young people, particularly in areas where the Ministry of Health is already actively involved?
Okay,
Dr. Chandra?
thank you. Yes, I'm happy to respond to that question. I'm also happy to make one additional point, and then I'm going to step out. See, I lived and worked in Zambia for 10 years, between 1982 and 1991. So this is, I'm 66 years old now. So some of you perhaps were not born at that time. This was the time of Kenneth Kaunda in Zambia and Kamuzu Banda in Malawi. Kaunda was a wonderful man. Anyway, so I ran a small NGO in the northern part of Zambia. Are there any Zambians on the call? If there are, please indicate with the flag. But I worked in the Copperbelt province of Zambia, and what we had in Zambia was we had a Zambian Association of NGOs or CSOs working on HIV. And we came together. We had some funding from Norway, from NORAD, and we came together in a national conference and we worked together. And the best way to strengthen your hand is collective action. I've already responded to that in the chat. Come together as a group. And if you're not already in a group, and when you come together as a group of 10 or 15 organizations, people listen to you. When you work individually, you can be dismissed or you can be pushed aside. So if you are a group of 15 organizations and you come together to represent yourselves to the WHO office or UNFP office, they cannot ignore you. Collective action. The second point is, I heard a lot of comments about Uganda's laws, and someone said, but the laws are not implemented. I come from India. I lived in Zambia for 10 years. For the last 30 years, I've lived in Switzerland. And what I want to tell you is we can sit here and complain about the laws and policies forever. Instead of that, my challenge to you is to organize another meeting and get people from your countries to speak about how we can bend the laws without breaking them, how within the framework of restrictive laws, NGOs are doing the best they can. For example, I have visited Mary Stopes clinics in Uganda, in Kampala, and they provide safe abortion care without calling it safe abortion care. They call it, completing an incomplete abortion. So there are many ways of bending the rules. There are many ways of even breaking the rules in cleverly and moving forward. And I think, while there are clearly, and you have absolutely, I think, Yoweri Museveni, when I was in Zambia, was a progressive leader. He and his wife, born again Christians, now they have become so restrictive in their approaches. The wife of the president is blocking comprehensive sexuality education. In this climate and with the Trump-Vance victory, this is going to get worse. But instead of complaining that the glass is empty, let's look for where the glass is even slightly full and celebrate that and aim to try to make the glass a little fuller. If you want my engagement in that, I'm very happy to do that. Remember, you can do things even when there are restrictive laws. Over to you, my chair.
Wow, thank you so much for answering that question and as well giving us a heads up on what to do. We shall be really, really happy to invite you as Ugandans. I am also coming from Uganda. We shall be really happy to invite you in such meetings. We have a few minutes to close, and I would love to have one more question to one speaker. That is Welisen. I don't know if I'm pronouncing your name very well. I'm so sorry if I'm messing up with your name. Are you ready? Can I go ahead?
Yes, please go ahead.
Okay, so what are the key actions or change would you prioritize to ensure that young people can access full range of HIV testing, treatment, and sexual reproductive health services? Over to you.
I'll start by saying that tailored programs for HIV treatment and abortion care are very vital for young people. These programs should focus on targeted outreach and education through community organizations and peer educators to provide relatable information. I'll also talk about comprehensive services which must integrate HIV treatment with sexual reproductive health, including safe abortion care. How can we have a situation where we say one-stop shop? When we have healthcare facilities that can be able to provide us with all of this, it becomes even simpler. Creating confidential and non-judgmental environments is essential, allowing young individuals to seek care without fear of stigma, with options of even anonymous services. Legal and rights education empowers us as young people to advocate for ourselves, while cultural competence training for healthcare providers even foster trust and open communication. implementing feedback mechanism ensures continuous improvement based on young people's experiences. The doctor said, even when the laws are restrictive, we can still work. When we are able to hear from the young people, then we can even begin to get richer insights on what works best for them. To me, these strategies create an inclusive healthcare environment that empowers us as young people to access necessary services confidently, improving health outcomes and reducing the stigma. Thank you.
Wow, thank you so much. I think you have really enlightened exactly what we are supposed to do, especially when we are working with young people and adolescents, and always prioritize giving them a chance to sit with them on the same table to know exactly what works for them. I think that that takes us to exactly why we are trying to like advocate for health services, for policies to change and laws in our different countries. And we have a few minutes to go. And if there is any question, if anyone would love to raise a hand, or maybe you can put your question in a Q&A or in the chat box. We can read them, or you can ask directly to a speaker in these few minutes. I think they can be able to like answer your question. Yeah, so still we can still follow each other on our social media platforms, or maybe that would be good for us to like connect and also know each other from different countries. And also as well, we should do more of prioritizing ourselves when it comes to healthcare and self-care, mental health, as the way Doctor was trying to teach us more about our brains, and then how adolescents are supposed to really work around each and everything. Yeah, if there is any question, and if there is anything else that any of the speakers would love to maybe comment on or maybe add before we close our meeting, this is the time. This is the time. If you have anything to say, please.
Good afternoon, everyone. Hi, Sharon. So I'd just like to add that it's very important to delink the age of majority and age of sexual consent from age of access to HIV services. But after that has been done, the next thing that needs to happen is you ensure continuity in the continuum of care. What do I mean by that? I mean that it may be possible that you have delinked the two and you've reduced the age of access for HIV testing, but then it's not really clear whether adolescents who have already undergone testing can have subsequent access to HIV treatment, PrEP, or other preventive measures. Because now, once you've already administered PrEP, and then that's for the one isolated incident. What do you do to cover behavior change or even to accompany the decision making of the adolescent when it comes to other forms of contraception, such as condoms and other options that they may pick for themselves? And in addition to that, I think it would also be important to really look at data deficiencies and any other evidence gaps as far as every country is concerned. The important thing about monitoring and evaluation is that when you can measure something, then you can improve it, right? So we keep talking about 95, 95, 95 targets among individuals aged between 10 to 19 years. But if there isn't clear, accessible data and evidence that is supporting the age of access policy and legal reform, then we will always be complaining about alignment of laws and policies with the international standards and falling short. Because then, in the face of a very strong opposition that speaks about Judeo Christian values, and these are flying in the face of science without an evidence base that can look values or assumptions in the face, then we may find ourselves not really actualizing the goals that we have set out for ourselves. Thank you so much for organizing this webinar, and let's go on with the conversation.
Wow, that was very, very important. Thank you so much, Margaret, for like enlightening us for that wonderful information. Is there anyone that would love to add on? I hear someone.
Yes, sir.
said.
Add on.
Okay, yes, Petra.
About what the speakers just said, the issue of consent is really important because in most cases, these adolescents are still facing a challenge of even receiving condoms or accessing condoms from hospitals and taking them home. It is still a hard thing for them to keep them at their parents' places. And the other thing, PEP is also something hard to access in most of the adolescents, and most of the adolescents still don't have information on PEP and PrEP, and also about their condom right usage. They still don't have information about that. Reason being is that the parents or the caretakers don't give them access or consent to the services they are supposed to receive just because of they think that they are underage. And to promote all that, to make all that come through, we need to make sure that the 95 are all put in order. So I don't know what the rest are doing, but me as an individual, I'm doing my best in the community to make sure that these adolescents access all of services and get to know about the 95s. Thank you.
All right. Thank you so much for that addition. There is one more question from Milta. Milta is asking that countries that are doing the 11 and 12-year-old are having access to treatment, etc. How compliant are they? Can any speaker come up to on this?
I'm happy to take this, Sharon.
Okay, yes, Martha.
So I'm happy to take this. So from a study that has been conducted, and maybe you can look at this from the HIV policy lab at the O'Neill Institute for National and Global Health Law, which is at the Georgetown University in Washington, D.C., you realize that Mozambique is leading with at 11 years for both age of access for testing, age of access for treatment, and age of access for PrEP. Now, age of access for PrEP is at 15 years. It has been a little bit lifted. And it would be great if Milta knows anybody from Mozambique to try and follow up to discover whether this is just reported or this is what is happening on the ground. And for countries that have got the 12-year, Rwanda is on the list, so is South Africa, Uganda, and those have got no restriction on PrEP. And then we have Burundi at 12 as well, Eswatini at 12, Lesotho at 12. So if you know anybody from any of those countries, it would be good to ask them about what happens on the ground, because then I'm not so sure about compliance from the side of the health facilities or for parents of children who are 11 and 12 years old, knowing that their kids can get testing, they can have access to HIV treatment, and that they can access PrEP.
Thank you so much for enlightening Milta. I guess now Milta is okay. Yes, I see she's saying thank you so much. They will get in touch. So I think this brings us to the end of our webinar. I would love to thank everyone that has participated. I want to thank the speakers. You have been very, very, very you have done a very good job to like enlighten us, and also to always give us a heads up on what to do when it comes to advocacy of abortion and age of consent laws and policies in our different countries. And if there is any, I don't know, I see. Okay, I thought there was another question. Okay, so I see there is no any other question, and we are on time. Thank you everyone for coming up. Thank you everyone for for attending, and also for the speakers. Thank you so much for coming and sharing your knowledge. We really appreciate that, and we are happy to always put you on board if you are available. Thank you everyone. We shall end the meeting now. Bye. Bye everyone.